Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Emily Ricketts will present Morning Light Therapy for Tourette's Disorder. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of 180 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such great impact is because we do not limit our focus to one illness or condition. Since 1987, the foundation has awarded $450 million to fund more than 6,500 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, PTSD, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Emily Ricketts. Dr. Ricketts is an assistant clinical professor in the Department of Psychiatry and Biobehavioral Sciences at University of California, Los Angeles. She was a 2021 Young Investigator. Our webinar will begin with Dr. Ricketts' presentation, which will then be followed by questions and answers. To submit your questions, please use the questions tab on the control panel on your screen. Please feel free to submit your questions at any time. Following the presentation, I'll ask as many questions as possible in the time allotted. And now, I'm pleased to introduce Dr. Ricketts. Emily, the floor is yours.
Thank you for the warm introduction. Well, hello, everybody. Again, I'm Emily Ricketts, and I'm an assistant clinical professor in the Department of Psychiatry and Biobehavioral Sciences at UCLA. I work in the Child OCD, Anxiety, and Tic Disorders program. So I'd like to acknowledge my funding sources. So the work that I will be presenting today stems from Tourette Association of America and National Institute of Mental Health funding. In addition, I've received funding from Brain and Behavior Research Foundation for study of other sleep intervention in Tourette. And also I've received funding from the American Academy of Sleep Medicine Foundation and National Heart, Lung, and Blood Institute's PRIDE program. And before I begin, I just want to acknowledge my collaborators and also local research coordinators at UCLA who have supported this work that I will be presenting. So just to provide some background on Tourette's disorder, also called Tourette syndrome. So really, Tourette's disorder is referring to multiple involuntary repetitive movements and one or more vocalizations lasting longer than 1 year, with an onset before the age of 18. For many in the public, Tourette syndrome or disorder conjures up really thoughts or images of people swearing and curse words and things like that. But that, that has really been sensationalized by the media, and coprolalia, which is the term for it, really only occurs in about 10% of cases. So I just wanted to clarify that before beginning. In terms of the prevalence, the worldwide prevalence is about 1%. The condition is more prevalent in males, at a ratio of about 3 to 4 males to 1 female, although that does become a bit less skewed in adulthood. So in terms of the course, so the onset is typically around 4 to 8 years of age. You know, the course is chronic and waxing and waning. So we know that, you know, tics fluctuate in frequency and severity over the days, weeks, months, years. They also change in topography over time too. So they're constantly changing in form and the types of tics that are present. They tend to peak in severity between the ages of 10 and 12, which you can see in the figure from Block and Lechman 2009 paper. And then, you know, after peaking, they tend to gradually decline during adolescent years, such that by early adulthood, they have reached, you know, none, minimal, or mild levels in about 80% of cases. And, you know, however, for about 20%, tics do remain at moderate or higher levels of severity. So we know that co-occurring psychiatric conditions in Tourette's are typically the norm. And so that is what this image is showing, you know, so basically just, you know, underneath the surface, there's a lot going on. So ADHD tends to be the most commonly co-occurring condition, followed by obsessive-compulsive disorder. But if not disorder, then sometimes just, you know, obsessive-compulsive symptoms or behaviors. Anxiety is certainly present as well, disruptive behavioral issues too, and sleep as well, so sleep issues. So in terms of the sleep disturbances that are present in Tourette's, so insomnia certainly is very common, if not the most common. Parasomnias, which are really referring to the unusual behaviors or actions occurring during the sleep period or during arousals within the sleep period. So things like sleepwalking, for example. Also sleep-related movement disorders like restless leg syndrome, bruxism, limb movements. Those are all common as well. And also tics during sleep can occur too. And there have been a few PSG studies, or I should say polysomnography studies. And so this is really referring to what people would call a sleep study. So you go to the sleep lab and you know, you're connected to you know, EEG that's measuring, you know, your brain waves, and then, you know, there's equipment to measure your breathing rate and, you know, muscle movements, eye movements, and all of that together. So sleep is regulated in part by our circadian rhythm, sometimes termed our 24-hour biological clock. Our circadian rhythm aligns our sleep-wake cycle and cognitive performance with the night and day cycle over an approximate 24-hour period. This rhythm is generated endogenously by a master clock housed in the suprachiasmatic nucleus of the hypothalamus. And peripheral clocks reside in the central nervous system and various tissues within the body. And many of these feed back to the suprachiasmatic nucleus. But it is entrained or synchronized by numerous time cues or Zeitgebers, with light being the strongest and most important one, and activity and feeding schedules also contributing. There is a specialized light detection system in our retina that directly projects to the central clock in the suprachiasmatic nucleus. It also regulates our core body temperature, key hormones like melatonin and cortisol, appetite, and also other body functions. And certainly, you know, disruptions to the circadian system can contribute to psychiatric illness. So sleep and circadian rhythms are modifiable to both our benefit and detriment. So we know that evening light delays sleep and internal rhythms, and that morning light advances sleep and internal rhythms. So there are a number of different ways to deliver light. And so here I've just, put some examples for you. So stationary white light boxes have historically been standard method for delivering light therapy. Certainly you can go outside and get some sunshine as well. Over the years, wearable devices have been developed to improve the feasibility of light therapy. And also, we have intrinsically photosensitive retinal ganglion cells in our retina, which project to the suprachiasmatic nucleus, and these are sensitive to short wavelength light, also called blue-green light. And so blue-green light devices have also grown in popularity over the years. Light therapy is associated with shifts in circadian phase, also improved sleep, and improvements of core symptoms for just a range of different psychiatric and neurological disorders. So there has been some prior interest in light therapy in Tourette's disorder over the years. So these are 2 case reports that describe use of light therapy for tics. So in the first, it was describing 2 15-year-old males with Tourette's who received morning light therapy via a light box for about 2 weeks. And this was at a light intensity of 2500 lux. They showed modest reductions in motor and vocal tic severity, and only about after 6 days of treatment or so, relative to a sham control that was administered 6 weeks later. In the second, so this was really a write-up based on a patient report. So a patient had reached out to Dr. Coles to describe their experience using light therapy. So this was a 52-year-old woman with persistent vocal tic disorder who reported rapid tic reduction from about 10 to 20 tics per hour to 1 or fewer per hour after using a light box at 10,000 lux light intensity for 2 hours each morning for 6 weeks. And this person noted tic worsening if they did not use the light box or spend time in the sun, and reduced tics upon restarting as well. And as I was saying before, so, stationary white light boxes have been standard, but, they are limited by just reduced adherence, just because in order to, receive the light, you do need to be kind of seated in front of the box. And so wearable devices do offer an alternative that allows you to be on the go as you are receiving your light therapy. And further, short wavelength light is known to be stronger at suppressing melatonin relative to longer wavelengths of light. It also produces similar circadian phase shifts as white light, but just at lower intensities as well. So this brings me to my aims. So I had done really 2 kind of combined projects, so 1 in adults and 1 in children. But the goal was, to pilot a 2-week course of wearable short wavelength morning light therapy and examine its effects on circadian rhythms, sleep, and clinical outcomes. But also, just because, we really have limited understanding of circadian rhythms in Tourette's, the other part of this study was to evaluate circadian rhythms in adults and children with Tourette. And in doing so, I also wanted to examine sleep, but knowing that, there have been several other studies that have done that too. So these are the aims. So first I'm going to talk about the adult study. And so in terms of the comparison, we had recruited 14 adults aged 22 to 50 years with Tourette's disorder or persistent motor tic disorder. This group of 14 also completed 2 weeks of light therapy. And then we had a baseline only healthy control group, and that was 20 participants. So in terms of the assessment, so when participants came in, we performed a screening assessment to diagnose Tourette's and any co-occurring conditions. They were then sent home with an actigraph, or sometimes called a sleep watch. And so this really is measuring movement. And so if one is moving long enough, it is deemed an awakening, and it is scored using a sleep diary. So needing to know the person's bedtimes and their rise times as well. And then this information is put into a scoring software, and the algorithm is applied, and then it computes sleep variables. And so they were sent home to wear the actigraph on their non-dominant wrist and use the sleep diary for 7 days. And then what we did is we asked them to come into the lab for what is called dim light melatonin onset assessment. And so we asked them to arrive about 5 hours and 45 minutes before their average bedtime and stay up until 1 hour after their average bedtime from this baseline monitoring week. And so what we were looking to do is establish the time on the clock at which their melatonin is kind of first beginning to rise in the evening under dim light conditions, because we know that light suppresses melatonin, so we need it to be kind of dimly lit conditions. And so this image is essentially what the room looked like. We use nightlight level lighting to create the lighting environment. And we made sure that it was below 5 lux using a lux meter, which measures the light intensity. And we measured the light intensity near their eye level. And I think the camera's picking up the lights, and they're looking bright, but they didn't look that bright in person. And so, for this assessment, the person is not supposed to have caffeine within 24 hours of the first sample, and no marijuana, alcohol, or beta blockers, anti-inflammatory medications within 72 hours of the first sample. And so what we're doing here is every half hour, after an initial 30 minutes of being in the dimly lit room, we take a saliva sample through a salivette, and then we send this information off for radioimmunoassay analysis. And so this is how we are assessing circadian phase. In terms of the light therapy protocol, so it was 2 weeks of morning light therapy. Participants were asked to continue wearing the actigraph for this period. And during this time, there were initial 3 days of phone calls at the time that the person was supposed to be wearing the device. So participants were asked to wear this at their average morning rise time from the initial 7-day monitoring period, or if that time resulted in, if that time really was a time that did not fit their schedule, did not leave them enough time to get to work on time, just because we recognize that an average across the 7 days of the week can lead to a time that maybe is not as feasible for a weekday, then participants were allowed to rise up to 1 hour earlier than this average. And so the time was fixed across the whole 2 weeks. And so the first 3 days there were calls to check in, and then subsequently text messages. And so the device that we used is called the retimer. It's a commercially available device. It emits, again, short wavelength light, 500 nanometers. It was worn on the high setting at 506 lux, and we would ask participants to wear it for an hour upon awakening, so immediately upon awakening. And then after the 2 weeks, we brought them back in for clinical assessment and also repeated dim light melatonin onset assessment. And so during the protocol as well, we also asked them not to consume caffeine after 3 p.m. They were also told that, they may begin to feel sleepy earlier in the evening, and if so, respond to that by going to bed. If necessary, nap after 12 p.m., but refrain from napping before 12 p.m. just because it can cancel out light therapy. And so those were the other components of the protocol. So in terms of the comparison of circadian measures, so here looking at dim light melatonin onset, so the clock time, just comparing, we used 2 different thresholds. So one of them was a standard 3 picograms per milliliter threshold. And so this is really getting at, what time on the clock does the picograms per milliliter of salivary melatonin reach 3, basically 3 picograms per milliliter for everybody. And so it is common to use, I guess it has been historically common to use a specific threshold. And for adults, it's been in the literature often 3 picograms per milliliter. But a newer way of looking at dim light melatonin onset is really to think about the time that it's just first beginning to rise in the evening. So the 3K method is the other approach that we used, and so this takes the average plus 2 standard deviations of the first 3 kind of saliva sample collections during the assessment, and these should ideally just be the low daytime levels, but right before it begins to rise. And so the advantage is that it's supposed to represent a kind of more natural, a natural dim light melatonin onset. But we did not ultimately find differences significant differences in circadian phase or dim light melatonin onset between the groups. We did look at morningness, eveningness preference, or sometimes called chronotype. So we used the morningness, eveningness questionnaire, and we did find that the Tourette group had a greater eveningness relative to the controls. So this is getting at your preference for either morning or evening rest or activity. And so, think about, if people have heard the term night owl or morning lark, that's what it is really getting at. And there are other ways to measure it, by self-report as well. So, there's a way to look more at the timing of your rest and activity, so the actual clock times rather than your preference. That would be another way. But the way that we used was morningness, eveningness preference. And so this is just a figure showing the difference. So the greater eveningness in the Tourette group relative to controls. And Also, in the comparison of sleep measures between groups, we do see some differences coming up. Longer sleep onset latency in adults with Tourette's relative to control. So this is referring to the minutes that it takes one to fall asleep. So it took longer. Reduced sleep efficiency. So this is the time that one spends asleep divided by the time that they were in bed, multiplied by 100. So it's a percentage. Fragmentation index. This is really getting at degree of restlessness during sleep. And also total sleep disturbance per self-report. It was also poorer in Tourette. So that was using the Pittsburgh Sleep Quality Index. We didn't see differences in wake after sleep onset. So the number of minutes spent awake after initially falling asleep, didn't see a difference in number of awakenings or just total sleep time, which is kind of like duration, really. So in terms of light therapy and its impact on circadian phase, we did see a significant circadian phase advance. And this is showing 3 picograms per milliliter, just as an example. So on the right, you can see the individual change by participant. And on the left, what you're seeing is the average rise in salivary melatonin across the evening for both the baseline and the post-treatment assessments. And you can see that it is, there is an advance, so it's shifting over to the left. On the bottom, we have time on a 24-hour scale. Yeah. And in terms of the impact of light therapy over the 2 weeks, just on the measures in general. So here, this is just showing you, what was statistically significant. So, there was a significant circadian phase advance, both for the 3K method and 3 picograms per milliliter method. We do see a significant reduction in anxiety using the Depression, Anxiety, and Stress Scale. There were improvements in daytime sleepiness using the Epworth Sleepiness Scale. And we used a clinician-rated interview to assess tic severity. So we used the Yale Global Tic Severity Scale, which is the gold standard clinician-rated tic interview. And we did see small, significant reductions in tic severity and tic-related impairment. We did not see a change in eveningness, so no change in chronotype. We did not see any significant changes in sleep disturbance, either based on actigraphy or self-report, or impairment, or depression. In terms of feasibility, so this is just based on self-reports, open responses based on just a number of different questions about favorite part of treatment, least favorite part, what would you like to be done differently, ways in which your natural schedule either facilitated treatment or interfered with the protocol, and these have just been adapted from prior Tourette trials. And so patients reported, sleep loss and burden just due to rising earlier, just to follow the protocol. A bit of an interference in their natural morning routine. Some decreased visibility from the light, and people who had more flexible work schedules found it a bit easier. There were some calming and alerting effects, and also one benefit was just being able to get up earlier and have more time in the morning. to oneself, and also just increased sleepiness at night and getting a bit more rest as well. So, and I should say those findings are already published, the adult findings. So those are out there, and now I'll dive into the findings from children. And so those, these have not been published yet or presented yet. So basically I did that protocol in adults, and I also did very, very similar protocol in children. So, you know, the sample was a bit larger in size, but it was 35 children aged 10 to 17 years with Tourette's disorder or persistent motor tic disorder. And 22 of those who were aged 13 to 17 completed morning light therapy. I also had 35 healthy controls, so a baseline only control group. And the reason that the ones who completed light therapy were 13 to 17 years was just based on the device and their specifications, just that the eyes can be a bit more sensitive to light for younger, younger children, and so we just cut it off at 13. So in terms of just demographics for the two groups, we did not see any significant differences there. This is a summary of the psychiatric diagnoses that were present. So most met criteria for Tourette's disorder. 4 had persistent motor tic disorder rather than Tourette's disorder. And I meant to describe that in the beginning, but that's just another type of persistent tic disorder where you've only ever had a history of motor tics and you've never had a vocal tic in your lifetime. There is also a persistent vocal tic disorder where you've only ever had persistent vocal tics and you've never had a motor tic in your lifetime. But we did not have anybody who had persistent vocal tic disorder in the sample. And ADHD was common as expected, 34.2%. Oppositional defiant disorder was present to a small degree. A few, a couple had OCD, but it wasn't common. Several had an anxiety disorder, but it was, this is a grouping of all the different kinds that were endorsed. And one had current major depressive disorder. A few others did have a history. So in terms of the protocol, it was really much the same. The only difference was that instead of asking the participants to arrive 5 hours and 45 minutes before their average bedtime for this dim light melatonin onset assessment, we asked them to arrive 6 hours and 45 minutes before their average bedtime and stay up until their average bedtime. So we did not ask them to stay 1 hour after, just because, we know they need to get home and get to bed. And, we just wanted to facilitate that as well. And so this is the comparison of the rise in picograms per milliliter of salivary melatonin across the evening of baseline between the children 10 to 17 with Tourette's and the controls. So, and we have the 24-hour time scale on the bottom. We do see that the Tourette's group is showing a significant circadian phase delay relative to the controls here. And then here, this is just similar information, but just shown a bit differently. So this is the clock time at which melatonin reached the specific threshold. So the clock time at which melatonin reached the 4 picograms per milliliter threshold. So I know for adults, I presented 3 picograms, which is common for adults, but for children, 4 picograms has been used in the literature, so we went with that one. And also use the 3K method as well to capture the low, the kind of low baseline daytime points before it initially, before it first starts to rise. And so we also do see the circadian phase delay in Tourette's here by comparison to the control group. And this table is really just showing you these differences in numbers between the groups. So we can see that it is, the Tourette group is significantly delayed using both methods, but looking at the children's morningness, eveningness scale, you don't actually see a significant difference here. And so typically, lower scores on this scale would mean a greater eveningness preference. And so, yeah, we don't see a difference in preference here. So in terms of sleep measures, these ones are self-reports. So this is from the Children's Report of Sleep Patterns scale. So these are 2 subscales, insomnia and sleepiness. We do see, and this is a child report questionnaire, we do see some significant reductions in self-reported insomnia and sleepiness as well. But we did not see any, we actually, just looking at actigraphy, we did not see really a reduction in, oh, sorry, I'm getting tripped up. Sorry, this was the, not reduction, comparing insomnia in Tourette and controls. So it just, and sleepiness. So we see, more sleepiness and more insomnia reported in the Tourette group relative to controls. But looking at actigraphy, we did not see significant differences in the groups. So, which that was surprising, just based on what we know about sleep disturbance in Tourette's. But, we do know that sleep does change during, adolescence as well for everybody. And so getting to the light therapy findings, so this is showing the rise in melatonin, so picograms per milliliter, concentration, salivary melatonin across the evening at baseline and post light therapy in our Tourette group that was 13 to 17 years of age. And so baseline is the dark green and post light therapy is the light green. And so, yeah, you can see that there was, there is an advance, and I will go through it here as well. So here we have, the same kind of figure that you saw before for baseline, but it's just showing, the shift in dim light melatonin onset clock time from baseline to post light therapy. And it, the lines are really connecting specific participants change over time. You can see some had a lot of change, some had very little change, some went in the other direction and delayed. And for the 3K method, it looks like, several did delay as well. And so this is showing the change in circadian phase, and also, morningness, eveningness from baseline to post light therapy. And so we really only see a significant circadian phase advance for the 4 picograms per milliliter threshold. We don't see it using the 3K method. And you can kind of see that on this graph here too, around the the 4, you can see the difference, but for the low baseline daytime points, there's just not much of a difference. And we don't see any change in morningness, eveningness preference over time. And that's, that's perhaps not surprising over 2 weeks as well. And then here is the change in insomnia. So this is the self-reported or child-reported sleep variables, insomnia and sleepiness. So what we see here is they're reporting a little bit less insomnia over the 2 weeks. We don't see a change in daytime sleepiness through the course of light therapy. In terms of clinician-rated tic severity, we do see a small significant reduction in total tic severity and also a small reduction in tic-related impairment. We don't see any significant changes in anxiety and depression, and those numbers are correct. They do just round to being the same. So in terms of feasibility from open responses for the children, a lot complained about device sizing and fit issues. And so, that is basically it's probably maybe a better fit for adults than for kids. So for this, we had used an additional kind of like a sunglasses strap that would, secure it to their head. But still, I think there was some slipping. Also, in order to track adherence and, just that the device was turned on and being used, we had Velcroed an actigraph to the inside. And so several complained of that being uncomfortable because it was just kind of stuck to one side. So that was another issue as well. And then there were some complaints just about the nose piece too. And some just talked about, just interference with their routine of just, with some people want to shower in the morning, or they're trying to get dressed and they're grooming, washing face, makeup, eating. One mentioned, they typically like to run in the morning and weren't able to do that. Some interference with, or I would say a lot of interference with sleep and the natural rise time schedule, because again, it was the same type of protocol. We were asking them to, really ideally wear it at their average rise time from the baseline monitoring week, but up to an hour earlier if they needed that time to, get ready for school and, wear it before going to school, essentially. And so that could, that resulted in some times that were pretty early. And so that can have, certainly implications if you're using light therapy, which I'll talk about in a bit. And also just feeling sleepy, both at initial rising, but also in the afternoons. Beyond that, favorable, I think perceptions were just, liking the way that the device looked, feeling like they could do some other things while wearing the device. And some reported that it helped with rising earlier and feeling tired earlier as well. And one parent did mention, so we had collected this information both from parent and child report. One parent mentioned that, their child would stay up late doing homework, and so it was hard, then to wake up in the morning. And that is a common problem for teens, having homework and things that they need to do and juggling extracurricular activities and all of that, their social schedule. So in terms of the summary of findings for adults with Tourette's, they showed greater eveningness and sleep disturbance relative to controls, but no objective circadian phase delay. For children with Tourette's, they showed greater objective circadian phase delay, but not greater eveningness or sleep disturbance relative to control. So kind of flip-flopped, and for both groups, there was a circadian phase advance, but no improvements in really eveningness or, I guess, the sleep, really. The only thing for children was the self-reported insomnia, but actigraphy, no, for the 2 weeks of light therapy. And for adults only, there were significant improvements in daytime sleepiness and anxiety. For both groups, there were small significant reductions in tic severity and tic-related impairment. And, as I've discussed, certainly some feasibility issues. The delays that we found in circadian timing are pretty consistent with just a larger body of literature linking, just delayed circadian phase with psychiatric conditions. One thing to think about is perhaps the role of comorbidity or the role of co-occurring psychiatric conditions. For example, we do know that there are circadian delays in ADHD and OCD as well. And so I think it would be important to understand their contribution here. And also just, beyond circadian timing, it seems like perhaps, these findings are really just preliminary, but it seems there could be more clinical benefit for adults than children, just based on, the daytime sleepiness and anxiety findings, or improvements for adults, but not for kids. And so in terms of limitations, so one of the limitations that was raised just during review of the adult study was just that, so one approach to examining circadian rhythms and performing light therapy is to place all participants on a fixed sleep schedule prior to bringing them into the lab, so that you can better parse sleep from circadian rhythms, and understand the circadian rhythms as distinct from what's going on with sleep. And so, for example, what you would do is you would ask participants to go to bed at the same time and rise at the same time for a set number of weeks to get them on the same schedule, and then you can study what happens thereafter with their circadian rhythms. So that is one limitation. We were not doing that. We just took the participants as they were and measured their circadian rhythms and sleep as it was. And certainly, these are small studies. So small case control study, but with small single group pre-test, post-test studies as well. So I have not used a control condition here. I don't have, this is not a randomized study where we've assigned some participants to active light and some to sham light, for example. And so that's certainly a necessary step in understanding how well this actually is working. Certainly, this was also brief. This is 2 weeks, and so this is really just a preliminary pilot. It's very brief, and changing sleep and behavior in general, takes time, and also, it can take time for the changing of bedtime to catch up with what rise time is doing as well, and so that is certainly a limitation as well. And then the other thing that came with just the type of design that I used, because I was trying to study 2 questions at the same time. I both wanted to understand whether circadian rhythms were delayed in Tourette's relative to controls, but also examine morning light therapy. I think the downside with that is that I was not recruiting people who who just had delayed circadian phase to do the light therapy, so it was mixed in terms of what I was targeting. I wasn't just saying, only people who have delayed sleep timing or delayed circadian timing join the study. I was really taking, people with Tourette's in general, and just if they met the age requirement, they got light therapy regardless of their, their circadian rhythm or chronotype. Also, just, some participants were on psychiatric medication, certainly, and that does, being on psychiatric medication can influence sleep as well. For implications for future research, so a longer duration of light therapy, 4 weeks or so, 4 or 5 weeks, I think would be beneficial. Having a sham control light condition, just to be able, and so that participants don't know what group they're in, and then we can better get a sense of their perceptions of change, as well as examining changes in tic severity and circadian phase too. And already mentioned this, but for light therapy, at least, including only participants with delayed circadian timing, just the people who need this treatment. And then, I didn't, in the beginning when I was talking about Tourette's, I didn't really go into the landscape for Tourette treatment, but the first line intervention per the American Academy of Neurology is CBIT, or behavior therapy for tics. And so this is a multi-element treatment package, but it involves habit reversal training, so training oneself to be more aware of their tics and any urges to tic, warning signs, and implementing an action that is physically incompatible with ticking, and also contingent upon tic occurrence or urge occurrence, and then also looking at the environment and how it might exacerbate tics, and really implementing interventions that reduce the impact of the environment on tics. And it has a few other components as well, like relaxation training, for example. But that is a first line intervention, and people have talked more just about how can we boost treatment response. So for that intervention has been trialed in adults and children. For children, the treatment response rate was about 52.5%. For adults, I believe it was 38%. For both, there were significantly greater reductions in the behavior therapy relative to the supportive, the psychoeducation and supportive therapy condition. But, the treatment response rate is just looking at those who are deemed as responding very much or much. And so, researchers are looking to ways in which we can boost treatment response. How can we combine treatments and get stronger effects? Because, different treatments are targeting different aspects of living with tics. And so, combining light therapy with behavior therapy might be one way to boost treatment response. The other, in terms of medications, so typically, the first trialed, ideally would be the alpha-2 agonists, guanfacine and clonidine, but also antipsychotic medications are used and have good effects as well, amongst a number of other medications. But daytime sedation or sleepiness is a common complaint for for tic medications, and so at least for the adults, they did report improvements in daytime sleepiness, and so light therapy could perhaps counter medication-related daytime sedation, and then just thinking about co-occurring conditions in general. The adults did report an improvement in anxiety too. So, light therapy could tap into, I guess, the co-occurring symptoms as well. And also, it'd be important to think about alternative methods of light therapy. How can we implement it in a way that is, most feasible for the person's schedule, and, make it so that they want to do it and they're able to do it. For example, for adolescents, a lot of times protocols will, at least what I've seen for behavior therapy and light therapy mixed together, they will use an advancing rise time schedule. So, for example, participants would be allowed to sleep in until their natural rise time on a weekend day, and that's when they would start light therapy, and then they would work backwards by half an hour every day or so. And so that is a different way to do it that may be more palatable. Also combining it with melatonin could be, another way to boost effects. And then another thing to just think about for future research is really just shared neural mechanisms between Tourette's and the circadian system. So we know that excess postsynaptic striatal D2 dopamine is hypothesized to underlie Tourette's disorder. And striatal dopamine does exhibit a circadian rhythm, and it is influenced by the suprachiasmatic nucleus through multiple molecular mechanisms. And conversely, dopamine receptors do regulate circadian function and striatal expression of genes, of circadian genes. So this could be a shared mechanism that could be worth exploring in the future. All right, thank you. And I know there were a few questions from registration, so I just want to try to answer those quickly. So one person had asked about whether this type of treatment might help those with severe OCD. So actually, the person who first, told me about, dim light melatonin onset assessment was Meredith Coles at SUNY Binghamton. And she had a student who was investigating this in, investigating circadian rhythms in OCD. I believe adults with OCD. And so that is actually how I first came to hear about it. And so Dr. Rebecca Cox now is actually doing a trial of light therapy in adults with OCD, and that is ongoing. She is a postdoc at Colorado Boulder. And then somebody did ask about a tremor, if this could be used for age-related tremor. I'm not sure about just general age-related tremor, but more, light therapy has been used for Parkinson's and tremor in that context, and it has been shown to help with tremor in that context. So, yeah. So I'm finished.
Great. Well, Emily, I just want to thank you for the work you're doing and for a great presentation. You really, I think, in a way that lets a lay audience understand how researchers think, how they develop a protocol, how they assess the protocol. This was an outstanding presentation, not only for people interested in this particular topic, just for people interested in the processes of research. And I want to thank you for doing that in really such a clear way. And obviously, we're looking forward to seeing your ongoing work, as this was an initial study, but I think it's going to lead to some very interesting findings over time. So I just want to thank you for joining us today and for your ongoing work, which is really outstanding.
Thank you very much. My pleasure.
Good. I also want to thank everybody who joined us today. I'd ask people to please consider making a donation to BBRF. 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. This means that when you donate $1 for research, the dollar goes directly to the scientist. To make a donation, please visit our website, bbrfoundation.org, or call 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it, please visit the events and webinar page on our website. And please join us again on September 12th at 2 p.m. Eastern Time, when Dr. Sarah Sperry, an assistant professor of psychiatry and adjunct assistant professor of psychology at the University of Michigan, will present a precision health approach to bipolar disorder. Thank you again, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Thank you.